We'll be beginning the webinar in just one moment. Good evening, everyone. Welcome to our East Coast participants. Good afternoon to our West Coast attendees. It's wonderful to have hundreds of you from across the country with us to discuss this important topic, financing the fight of your life, financial assistance for prostate cancer, brought to you by ZERO, the End of Prostate Cancer, in partnership with Janssen Oncology and Novartis. I'm Shelby Moneer, Vice President of Patient Programs and Education at ZERO, and I'll be your host today. Before we begin, I'd like to go over just a few housekeeping items. First, today's webinar is being recorded and will be posted on our website, zerocancer.org, tomorrow. As soon as the webinar closes, you'll see a link to a survey, and we would love for you to participate and provide feedback on this event. Tomorrow, you'll also receive an email with a link to the recording and the survey. In addition, this program is being live streamed on ZERO's Facebook page. For those of you not already familiar with ZERO, the End of Prostate Cancer, we are the leading national nonprofit with the mission to end prostate cancer. ZERO advances research, improves the lives of men and families, and inspires action. We are building Generation Zero, the first generation of men free from prostate cancer, through our National Run Walk series, education and patient support programs, and our grassroots advocacy efforts. If you are new to the ZERO community, we welcome you. First, I want to thank Monica Bryant and Jasmine Pugh, our featured speakers, for sharing their time and expertise with us today. I also want to thank our program sponsors, Janssen Oncology and Novartis, for their support. A quick overview on what we're going to go over through our agenda. After these introductions, I'm going to share with you some of the resources that ZERO has available to you at no cost. These include financial assistance and patient support programs. Next, Monica will present on avoiding financial toxicity. We will then take a few moments for some Q&A. Following that Q&A, we will have Jasmine present on ZERO360, and she will provide some insight on her experiences as a ZERO360 case manager. This case management program assists people in overcoming financial obstacles and helps them access much needed resources. We will then take some time to ask Jasmine a few questions. I will then come back on and conclude with just a couple of additional ZERO resources that we have at no charge for our patient and caregiver community. So to make this next hour as interactive as possible, I would encourage you to please ask us some questions. We will get to those questions throughout the event, and then hopefully at the end as well. You can ask a question at any time by typing it in the Q&A box at the bottom of your screen. And like I said, we will do our very best to get those questions answered to you during this event. So let's get started with just a few introductions. First, we're going to start with Monica Bryant. It's my pleasure to introduce Monica to our ZERO community. Monica Fozzie Bryant is a cancer rights attorney, speaker, and author dedicated to improving access to and availability of quality information on cancer survivorship issues. Monica is the co-founder and chief operating officer for Triage Cancer, a national nonprofit organization that provides education on the practical and legal issues that may impact individuals diagnosed with cancer and their caregivers through various events, materials, and amazing resources. Throughout Monica's career, she's provided hundreds of educational seminars, written articles, blogs, and even co-authored a book published by the American Bar Association called Cancer Rights Law: An Interdisciplinary Approach. Monica is also an adjunct law professor at John Marshall School of Law in Chicago, teaching a class on cancer rights. Our next speaker will be Jasmine Pugh. Jasmine is one of ZERO360's case managers. Her primary role is to assist patients with navigating and overcoming barriers that present themselves before, during, and after treatment. Prior to joining the nonprofit sector, Jasmine worked with local and federal government programs such as Social Security Disability, Medicaid, SNAP, and TANF. Additionally, she has experience in the healthcare field, providing rehabilitative patient care. Jasmine holds a Master of Arts in Law, Wealth and Financial Management, and a Bachelor of Arts in Sociology. So set the stage for this webinar, I wanted to briefly share a couple of fairly staggering statistics that really highlight some of the difficulties 2020 has brought to the United States and the world. These really highlight what we're living through, what we continue to live through for the foreseeable future, and really expresses how important this type of webinar topic is to cover and to provide to our community. According to the US Bureau of Labor Statistics, and something I think we all know, but it's really alarming to see on a slide, is that the unemployment rate shot up to a record high of 14.7% in April of this year, really in the thick of the pandemic in March and April. But what that equates to is 23 million unemployed persons in America. And what's even more staggering is the Pew Research Center estimates that unemployment for Asian, Black, and Hispanic workers is likely even higher during that time period, closer to even 20%. These challenges, as you know all too well, are really, it's just a ripple effect and cascading down through our home lives, after our work lives, and into our daily lives with our families. These challenges have stemmed from the COVID-19 outbreak, as we know, and as an effect of this unemployment, we've seen food insufficiency, especially in households with children. We've seen Americans struggling to pay for common household expenses, these usual expenses, having difficulty paying rent, and even foregoing medical care because they are having trouble with transportation. So I wanted to put some numbers on this slide to really highlight the effects of the COVID pandemic, the unemployment, the difficulty in paying bills, to set the stage for our amazing speakers and them sharing the resources that we are so lucky to hear about. In September, the ZERO team proudly launched an amazing new program, a new webpage, developed specifically to highlight various financial resources that are out there. They are organized by type of resource that you might need, the reason that you might be needing that extra support during this time. This webpage can be found at zerocancer.org/financial. This page is full of information, highlights our patient resources, discusses what educational videos might be helpful to you during this time, and also highlights some COVID-19 specific information that you might find useful. So please take a moment to visit that webpage and take a look at the resources and support options out there for yourself. Lastly, I wanted to talk just very briefly about our program ZERO360, and we're going to dive into this in just a moment as we hear from both Monica and Jasmine. But I wanted to highlight this quickly to set the stage again for our speakers and to dive into this. ZERO360 launched in 2016, and we're so proud of this program. It's an extremely high-touch program. You can see that bottom bullet. On average, our amazing case managers average about 15 contacts per patient call. These contacts and the fact that our case managers work so hard and so closely with our patient community and with social workers on the ground and with insurance calls has saved over $2.6 million for our patients through this program, and more than 2,000 people have been assisted in support resources and in debt relief programs. So with that, I'd like to now turn it over to Monica Bryant to share with us some of the strategies to help avoid financial toxicity. So thank you, Monica, for joining us, and you now have the floor.
Thank you so much, Shelby. I am delighted to be here today to talk about some strategies and ways to avoid financial toxicity. So as Shelby mentioned, Triage Cancer is a national nonprofit that's focused on providing education on the legal and practical issues that may arise after a cancer diagnosis. And oftentimes when I talk at these events, people are very confused as to why there is a lawyer on the panel. But the reason is that many of these programs and the rights and benefits that you're entitled to are in fact rooted in the law. Even things that you might not consider as legal, like access to health insurance, is in fact rooted in the law. So today's going to be a pretty high level overview given the amount of time that we have together, but I do just want to point out that in addition to Zero's fantastic resources, Triage Cancer also has some free resources available on our website and free educational events because today is just going to be a very high level introduction. We want you to know that after tonight, there are certainly resources to continue supporting you. You will also note that we have charts of state laws, and that's because where you live can impact what rights you have access to. And so what might be available in somebody else's state may not be available in your state. And we have that information on topics like employment, health insurance, and estate planning, all included in our website. So this term financial toxicity was coined in 2013 out of researchers from Duke. And in their research, they really focused on how the out-of-pocket expenses that result from cancer treatment can impact somebody financially. And that financial burden or financial toxicity is very akin to the physical toxicity that many people experience. But what was particularly interesting about what they focused on is it was not just about how the financial burden occurs in an acute way during active treatment, but also how there's this long-term or long-lasting financial impact that can diminish somebody's overall quality of life. Now, it's a relatively new term, but it is certainly not a new problem in the cancer community. So why is it so hard to address financial toxicity? Well, it's because there's multiple contributing factors. And I would argue that the number one biggest contributing factor to financial toxicity is health insurance status. Now, for some people, that means not having health insurance, but for others, it means not having the right health insurance policy for you, and then not effectively navigating or utilizing that health insurance. Certainly, the employment changes that can occur after a cancer diagnosis, both for the individual who's diagnosed and the potential caregiver, can have an impact on financial health. And then what do they have access to with respect to income replacement options? So things like disability insurance. And then, of course, all of the things that happen in life that impact your finances continue to happen even after a cancer diagnosis. So relationship changes or moving are going to impact your finances. And now we're just compounding the issue of financial toxicity. So that's the bad news. We have some good news in that there are actually things that we can do to avoid the financial toxicity. And I realize that this is very hard to read on the screen, but this is a visualization of many of the questions that can be asked of someone, regardless of where they are on the continuum of care, to start figuring out places where they can either reduce or avoid the financial toxicity altogether. And as you can see, it really does run the gamut from insurance coverage to practical issues, like do you have to travel for treatment, to personal issues, like what does your family look like? And then your employment situation. So if you go to this link on the bottom of the screen, you'll get the full-size version of this checklist. And on that full-size version, it not only has these questions listed, it also has the resources that we have to help you address the answers to those questions. But as I mentioned, health insurance status is the number one contributing factor to financial toxicity. The challenge in that is that in order to avoid financial toxicity, we have to be able to pick the right policy for us and then understand how to use it. Except nobody in America understands health insurance because it's confusing. We often say there should be a class in high school on finances and health insurance because we all have to use it, but none of us are ever taught. It's like learning a new language, but no one's teaching it. So if you feel like you don't adequately understand health insurance or you wish you knew more, you are certainly not alone. So I'm going to start off back to the basics and hopefully get us all on the same page. There are 3 places Americans get health insurance. The largest number of Americans get their health insurance through an employer. The next largest group get their health insurance through the government, primarily through Medicare and Medicaid. And the smallest number of Americans go directly to a health insurance company to buy health insurance. But regardless of where you get your health insurance, there are terms that are going to be used that are incredibly valuable to understand. So when we talk about the cost to have health insurance, that actually means several different things. So first, there's your monthly premium, which is what you have to pay monthly just to have the policy. And you're going to pay that whether you go to the doctor or not. It's like having car insurance all year, but you never filing a claim. That's your monthly premium. But then there are some additional costs that you're going to incur when you actually use your health insurance. Your deductible is a fixed dollar amount that you have to pay each year for the deductibles are to plan. You could have a plan with a $500 deductible. You could have a plan with a $5,000 deductible, but it's always going to be a fixed dollar amount. The next is your copayment. And this is going to be another fixed dollar amount, and it's going to depend on your plan, but you're going to pay it each time you get care. So for example, many policies have a $25 copayment when you go to the doctor, or a $250 copayment when you go to the ER. Finally, there's your cost share or your coinsurance. And this is a percentage, and you're going to pay it each time you get care. And it's the difference between what your health insurance company covers and what you're responsible for. So the first thing you always pay is that deductible, and then the insurance company starts picking up their share of the costs. Arguably, one of the most important things to understand about your policy is if there's an out-of-pocket maximum. Because in theory, the out-of-pocket maximum is the most you're going to pay for your medical expenses each year, in addition to your premiums. And the way you get to that out-of-pocket maximum is by adding up everything you pay towards your deductible, everything you pay towards your coinsurance, and everything you pay towards your copayments. So it's literally everything you're paying out of pocket, except those monthly premiums. Now, I will say the devil's in the detail with all of this. So typically policies will only count payments made towards in-network services towards that out-of-pocket maximum. I will also say that if you have an employer plan, they might have a slightly different equation. So they might carve out the deductible from your out-of-pocket maximum. So if you have an employer plan, incredibly important to look to that specifically. So here is an example of how this all works. Meet Dan. Dan has a policy with a $2,000 deductible. It's an 80-20 coinsurance, and it has an $8,000 out-of-pocket maximum. Dan gets into an accident and ends up with a $102,000 hospital bill. So what does Dan have to pay? Well, he hasn't gotten any other medical care for the year. So the first thing you always have to pay is that deductible. That leaves $100,000 left of the bill. He has a 20% coinsurance, which is $20,000. But he has that out-of-pocket maximum. So what of that $20,000 does he actually have to pay? Only another $6,000 because he's already paid $2,000 towards his deductible. So he's paying a total of $8,000 out of pocket. Now, I'm not suggesting that $8,000 isn't a lot of money. Of course it is. But when we start looking at the alternatives, it feels slightly more reasonable, or I should say relative. Now, if you would like to hear any of that again, the terms and this example, that's included in one of our animated videos that's available in English and Spanish. So you might share with your friends. Now, when we're talking specifically about Medicare, Medicare is incredibly confusing because there are multiple parts and it's not always obvious as to what each part covers. So here are some basics. With Medicare, there are generally two lanes you can drive in. The first lane is termed Original Medicare. And that's where you pick up Part A to cover hospital services. You pick up Part B to cover your medical insurance. And so that's going to be things like doctor's visits and immunizations and scans and tests. IV chemotherapy is also included in Part B. Then you decide if you want coverage for prescription drugs, and you pick up a Part D plan. Now, in Original Medicare, with Part B and Part A, there are out-of-pocket costs. Part B has a 20% coinsurance and no out-of-pocket maximum. So it can be very expensive to have Part B out of pocket. There is a solution to that problem in that you can purchase an additional insurance plan called a Medigap plan, also known as a Medicare supplemental plan. And these plans will pick up the out-of-pocket costs associated with Part A and Part B. So that's lane one. But it turns out that potentially dealing with 3 different premiums and deductibles and cost shares is complicated. So an alternative was created in Part C, otherwise known as Medicare Advantage. And these plans are sold by private insurance companies. And so the costs are going to vary company to company, but it's going to cost you at least the same as it would cost you to have Part B. What's interesting about this lane is that you're going to get all of the services you would get under Part A and Part B bundled under one plan. About 90% of Medicare Advantage plans include prescription drugs, but if you pick one that doesn't, you can pick up a Part D plan. Now, there are pros and cons to each one of these lanes, and there is no one size fits all. One of the major differences with lane 2 is that Medicare Advantage plans come with an out-of-pocket maximum. So now people usually say, well, wait a minute, why would anyone drive in lane 1? Well, one of the major reasons is that with Original Medicare, it is called fee for service, which means you can go to any provider around the country that accepts Medicare and receive services. Whereas lane 2 comes with a network of providers that's going to be significantly more limited than Original Medicare. So again, no one size fits all, but you're going to want to pick one of these 2 lanes to drive in. Now, that was the 50,000 foot view of Medicare, but because we are currently in open enrollment for Medicare, I wanted to make sure to share some additional resources for you so that if you have questions or want more in-depth information, you can access that. Now, depending on what type of insurance you have, enrollment periods are going to be different. So if you have Medicaid, and that's the federal program for individuals with low incomes, and in some states, low incomes and low asset levels, applications are accepted year-round. So as soon as you become eligible for Medicaid, you can apply. If you have a plan sold through the state health insurance marketplaces, open enrollment for most states is going to be between November 1st and December 15th. I say most states because some states run their own marketplaces and have longer open enrollment periods. And that's the kind of information you can find on our chart of state laws. Medicare, as I mentioned, also has an open enrollment period every single year between October 15th and December 7th. Now, marketplace plans and Medicare plans are calendar year plans, which means even if you pick a policy on day 1 of open enrollment, that policy doesn't start until January 1st. So you're going to want to make sure you maintain coverage until then. With employer plans, they also have annual enrollment periods, but the timing can vary. Typically, employers pick a fall open enrollment to coincide with the January 1 start date, but not always, so valuable to check with your employer. Thankfully, the system understands that things don't just happen during open enrollment. So all of these entities have what's called special enrollment periods, which is if you experience a loss in coverage, like you're leaving your job, or you have a life-changing event, like your household size is increased or you've moved states, that's going to trigger, in most instances, a special enrollment period for the marketplaces, for employer plans sometimes, and Medicare also has a special enrollment period. For Medicare, the special enrollment period most often comes up when someone works past the age of 65 and keeps their employer insurance. And then when they stop working, they get a special enrollment into Medicare at that point. So the good news is we have more options than we've ever had as consumers of health insurance in the past. So how do we actually go about making choices between those various options? I'm going to go give you an example using the marketplace, but the analysis I'm going to teach you is valid whether you're trying to compare to marketplace plans or to plans that your employer might provide you, or if you're trying to decide, do I take my employer plan or is a marketplace plan better for me? Or even if you're trying to decide between two different Medicare plans, the analysis is exactly the same. So here we have a situation where there's three different policies: a bronze plan with a $173 monthly premium and a $6,000 out-of-pocket maximum, a silver plan with a $271 monthly premium and a $5,200 out-of-pocket maximum, and a platinum plan with almost a $400 a month monthly premium and an $1,100 out-of-pocket maximum. So assuming that I'm going to hit the out-of-pocket maximum for the year, which is often a valid assumption when we're talking about cancer care, which plan would cost me the least at the end of the year? The trick here is that you can't tell just by looking at this. You actually have to do the math. And the way that you do the math is you take that monthly premium and you multiply it by 12, because that's how much you're going to pay in premiums for the year. And then you add the out-of-pocket maximum. And when you do that, you'll see which plan is actually going to cost you the least come end of year. And in this example, it does end up being that platinum plan is over $2,000 less expensive. But there are also some other benefits. So the $0 deductible, which means that plan's going to pick up 90% on day one, as compared with that bronze plan where you'd have to write a $6,000 check before the policy started paying anything. Now, we do this all over the country, and wherever we are, it never comes out the same twice. The point is, we often look just at that monthly premium and get sticker shock sometimes without actually doing the math. So certainly, in addition to looking at the cost, we want to make sure that whatever plan we pick includes the doctors and hospitals and facilities that we use. Because if you are going outside of that network for care, those payments typically won't count towards your out-of-pocket maximum, and some insurance policies won't provide coverage at all. So it's not just about finding the cheapest policy, it's also about finding one that meets your needs. Similarly with prescription drugs. So before you pick a policy, you can now look to see if that policy is going to cover any of the prescription drugs that you're taking and at what rate. Also, some policies have a separate deductible for prescription drugs. And so while that's not inherently bad, it is valuable to understand. The other unfortunate reality, in my opinion, is that picking a health insurance policy is not a one-time chore. It is something that we have to be doing every single year. And that is true if you get something through your employer, because it's valuable to look at what's available to you in the marketplace, because it may actually be better than what your employer is providing. That's true if you are in a marketplace plan, because what's available in the marketplace changes every single year. And that's true if you're in Medicare as well, in either lane, because checking to make sure that the Part D plan meets your needs or the Advantage plan meets your needs is very, very valuable. So something that we have to do every single year, add it to your annual to-do list. And really right now is the time for most of us to be making those choices. Oh, geez, I'm sorry, I forgot about this slide. So obviously today I focused on health insurance because it really is the #1 contributing factor, but there are so many other pieces that come into play when we're talking about finances and financial health. And so understanding what your rights are with respect to access to disability insurance or to take time off that's job protected and health insurance protected, to understand estate planning and stress management. These are all pieces that play into financial health. And so this is just a screenshot of our website. So in addition to Zero's fantastic resources, please know that Triage Cancer wants to be a partner and helpful to you as you navigate all of these challenging topics. So with that, I'll turn it over to Shelby.
Thanks, Monica. That was such a wonderful recap of, I think, what to most and many is really confusing and hard to digest and information overload. So thanks for capturing all of that information in such a concise way. And also thanks for sharing Triage Cancer's amazing resources. They are so wonderful. So I encourage all of our listeners to take a minute and hop on their website and dive into the amazing videos and resources. We talk a lot at Zero about hearing things multiple times to help with understanding. So the videos in the written format and by listening to this webinar, hopefully it will become a little bit less overwhelming and confusing to our community. If you don't mind, Monica, we do have a question from a listener, and it's specific to Medicare and also the Medigap plan that I think a lot of individuals are not overly familiar with. So the specific question was, these are still very expensive, and this person was wondering if there is any financial assistance to help pay those premiums. So if you can talk at all about that, that would be helpful. And then I think maybe just one or two more sentences on the Medigap plan itself might be really helpful.
Financial opportunities they based on income level, specifically to cover the out-of-pocket costs in Parts A and Parts B. Those plans are called Medicare savings programs. And there's actually 4 different programs, and they're very complicated to talk about today, but we do have one of our quick guides on those savings programs. When you're talking about Part D, which is the coverage for your prescription drugs, the financial assistance is called extra help or low income subsidy. So it's 2 names for exactly the same thing, which is a common problem in health insurance and adds to the confusion. But again, that's going to be based on income level. Now, the Medigap plans, as I mentioned earlier, are additional insurance policies that you can purchase if you are driving in that lane 1 I was talking about. And what they are is they're policies that you buy from private insurance companies, and they're identified by letters A through N, not to be confused with Medicare Parts A through D. So we couldn't come up with any better naming system, but here we are. It's very complicated. Now, these plans will pick up the out-of-pocket costs associated with Parts A and Parts B. So that 20% co-insurance, for example, I mentioned in Part B, there are Medigap plans that will cover all of it. The challenge for a lot of people is they get to Medicare eligibility and they probably are getting Part A premium free because of their work history. But Part B has that monthly premium. Part D has a monthly premium. And now we're saying, can you buy this additional insurance policy to cover your out-of-pocket costs? And it feels very overwhelming. But often when you do the math associated with what it would mean to pick up that Medigap plan, it can end up saving tens of thousands of dollars. So it is important to actually do the math and figure out, well, what are my out-of-pocket costs going to be based on my medical conditions and the services that I receive, and to actually do that math to see if paying a little bit more monthly, again, a little bit, it's all relative, monthly in a Medigap plan is actually going to be financially beneficial to you, and not just to get that sticker shock of now you want me to buy a whole nother policy. because it is expensive. And unfortunately, we just got the 2021 numbers and everything is going up again. But if you'd like some more information about Medigap plans and how to make choices between the different plan letters, we have that quick guide on Medigap plans as well. And I do, in our webinar that I've given you the link to, we spend quite a bit of time talking about Medigap plans as well.
Wonderful. Thanks, Monica. Thanks again for your time today. Zero values you and Triage Cancer so much. We have a couple of questions continuing to roll in that I think we'll be able to tackle at the end of the webinar. So as a reminder to our listeners, please, if you have a question, pop it in that Q&A box at the bottom of your screen. You can also ask the question on Facebook. If you're watching on Facebook, we'll capture your question and get that answered there as well. Excuse me. So thanks again, Monica, and we hope to have you jump back in here at the end of our webinar for some more Q&A.
Will do.
Now we're going to hear from Jasmine, who, as mentioned earlier, is one of ZERO360's case managers. Jasmine helps provide cancer patients and their families everyday guidance through the program. So thank you so much, Jasmine, and I will let you take it away.
Hi, I hope everyone is doing well today. I'm really excited about being here to share with you all because I love my job. I am a case manager with ZERO360, and much of what Monica talked about is basically the premise of my job. So I'm here to help patients overcome these exact things that she talked about as far as financial toxicity. If you could please advance the slide. So Zero on the end of prostate cancer, we do have a helpline here for the patients. You can reach us Monday through Friday, and you can do so by calling 844-244-1309. So on that line, you will get an intake specialist who's in charge of gathering your information and inputting it into a system where you will be assigned a case manager. The case manager will then try to assist you with your issues. So a lot of people get alarmed when they immediately call and they share all of this information, but the intake process is just there to gather your information so that the case manager can do the necessary research before they call you back and address your issue. So first, we just want to discuss, I want to discuss some of the roadblocks that patients tend to face as far as access and affordability. Almost on a daily basis, patients are calling us because either they're starting treatment and they're facing some roadblocks, or they're in the middle of treatment and something has happened and the roadblocks are there creating barriers. One of the first one, as Monica talked about, was insurance access. Lack of insurance with high out-of-pocket requirements, issues with service limitations, and low insurance literacy definitely contribute to some of the routine barriers that our patients face. What we do with these cases a lot of time is a lot of education. So we start with educating the patients on the type of insurance they have. Many times I ask my patients personally to send in their insurance policy so I can read through with them what their out-of-pocket costs might be, what their coverage limitations are, so that they can understand simply what the financial counselor at their cancer center has told them in layman's terms. That's a lot of the issue. Now, if the patients don't have insurance or their insurance has high out-of-pocket requirements, that is another barrier. And the way that we overcome those is by looking for available insurance options. There are many times when there aren't any, to be honest. And outside of marketplace open enrollment, if they aren't able to get a special enrollment periods, we have to go into whether they qualify for government assistance, whether they will qualify for charity assistance, locating hospitals, locating cancer facilities that will agree to see these patients on a charity basis. Also with Medicare patients, there are requirements that Medicare has specifically. So I have to work with the doctor's offices to see if we can do some type of negotiating to help overcome those barriers. Which brings on a very common issue, which is medical debt and their ability to pay. Patients have plenty of providers. Even before being diagnosed, they often have 3 or 4 people that they see on a regular basis. But once they get diagnosed with cancer, they will have additional specialists, labs, different procedures that they have to have done, and they will have several different bills. Our job is to try to help them handle that debt. Most often it's an issue of patients being overwhelmed. Once they get overwhelmed, they don't even open the bills anymore. So many times the beginning of our process is to have the patient sit down, open the bills, sort through the bills so we can call with them to see what the options may be to help them overcome these debts. We do a lot of negotiating. We do a lot of arranging for payment plans. We apply for charity programs with our patients. We also tend to see if they'll take a good faith payment. Some of these medical facilities, they have very strict requirements on their payment plans, but many times patients are just interested in protecting their credit. So if we can just get the hospital to accept a good faith payment to keep the bill out of collections, our patients are satisfied even with that resolve. A lot of these bills sometimes can amount to, honestly, bills the patient may never be able to pay in full. A lot of our patients are lower income individuals. So if you're making $14,000 a year and you have, medical bills of $22,000, $23,000, at that point, you just want to protect your livelihood, make sure you don't end up in court over the bills, make sure you can continue your treatment, and that's what we're here for. We also deal a lot with employment protections and workplace entitlements. Commonly, patients who get sick have never been sick. And I don't know how to say that, but many of the patients who find themselves in a situation where they've been diagnosed with cancer have never had an illness that has taken them out of work. Because of that, they don't know about short-term disability. They don't know about FMLA. They don't know about the American Disability Act. They don't know about COBRA. Because of these things, their job goes into jeopardy because they don't follow the correct protocols into getting these protections implemented on their behalf. That's where we step in. We provide that education and that guidance. We will call someone's HR department to see what they're eligible for. We will figure out if they have a short-term disability policy or a long-term disability policy and assist them with putting in the application for those or recovering the correct medical records to ensure they can continue those policies. We work very diligently to help people maintain their employment because we know that once the employment leaves, the patient is in a far worse situation financially, which will definitely have a serious impact on their ability to have quality care. There is also severe cost of living impacts. And when people get ill, their income is usually impacted and they have an issue with maintaining their basic needs. Housing, transportation, food, and utilities, those are the most common, but there are others as well. For instance, I may have a patient who makes $200,000 a year, but all of a sudden they become ill and we have to file a disability claim for that person. One of the first conversations I have with that patient at that time when we file for disability is, I want you to understand that your income is going to decrease substantially. So what types of living, what are you willing to give up in your living situation? What types of concessions are you willing to make in your living situation? We want to try to catch it on the front end so that the patient doesn't get in a situation where they can't pay their mortgage, they can't pay for their car payments, or provide for their families. Emotionally, that takes a toll on a patient, but outside of that, if a patient can't handle their day-to-day expenses, then they start to negotiate whether or not they're going to continue their treatment, whether or not they can afford the quality treatments. So we try to get all of those barriers out of the way, whether it be with calling the mortgage company sometimes with the patient to see if they're eligible for a hardship program. The same with car lenders, locating local resources that the patient can use in order to pay for their rent, pay for food pantries. It's a lot of different things that we do in that arena, but for the most part, we definitely try to catch it on the front end. Sometimes it's been an ongoing issue, so we have to try to overcome that barrier as well. And last but not least is the emotional distress. Within the ZERO program, I find it most often that there's a lot of underlying emotional distress with my patients. Men who have been the breadwinner in their families for 30 years, all of a sudden you can't work and you can't pay your bills, and your wife has never worked. Emotionally, the toll that that takes on a man is very significant, and a lot of times we have to dig through that before we can even get to the issue, because they're not as forthcoming with how they truly feel or everything that's going on. Also emotionally, with the side effects of just not being able to afford your treatment and being angry with different systems, not understanding why when you're sick, you're not able to get the help that someone else that you know got. The emotional trauma is very important because it will impact their overall health. It's been studies that have shown patients who are in a better emotional standpoint do better with their treatment, and they recover better during their treatment. So the first thing I do is always start with asking my patients, how are you? You know, how are things going? You know, how is your wife? You know, just to double check in with the patient to make sure they're okay. Because before we can even begin to talk about the finances, I want to let them know that I'm here to just listen, so that they don't feel intimidated and they don't feel like they can't ask anything of me, or they don't have to be prideful about the fact that they're behind on their bills, or prideful about the fact that they can't afford their medications. This is not the only thing we do here, but this is a good idea of just how we start our processes. Next, I just want to go through some case studies fairly quickly. These case studies have to be very specific. So there is some information that I can't divulge, but I do want everyone to know this is not all that we do. So as Shelby stated, it takes several contacts to solve an issue most often. And so it's very important to know that this is just a slimmed down version of what actually happens. So this first one is a Hispanic male in his 50s. He's insured and he needs assistance with transportation. So since he was diagnosed with prostate cancer a year earlier, he had already undergone surgery and was scheduled to begin radiation treatment at a hospital 20 miles away. He needed help with the cost of transportation and radiation treatments. The case manager assigned to this case educated the patient about open enrollment, if he needed changes to his healthcare plan to look for better coverage for his radiation therapy. Radiation is one of the trickier procedures when it comes to prostate cancer. When we have patients who are undergoing chemotherapy, a lot of times we can go to manufacturer assistance programs to try to get them help with the cost, or we can look for copay programs. However, with radiation, that is not always an option. So we have to discuss payment plans and strategies to offset the cost of the radiation, because many times the radiation is a rate that they have to pay weekly or daily. We also, with this patient, connected him to a national organization that would provide transportation to treatment and he was qualified to receive that. This has been a little bit trickier, to be honest, since COVID. Transportation is a serious issue right now because many of the programs that we normally lean on to provide the transportation for the patients who cannot drive themselves are not currently running. So we're having to come up with different alternatives to address the transportation issues. This next case study is a Caucasian male in his 50s. He's insured and diagnosed with stage 4 prostate cancer, and he needed assistance with medication expenses. So he was in active treatment, meaning that he hadn't begun treatment yet, and he needed assistance paying for his prescribed medication in order to avoid going into debt. This is common, especially with certain medications that are extremely expensive, and either Medicare or the personal insurance policy does not cover it beyond the patient still owing a couple of $1,000s. So you can imagine if you are a patient, you're already struggling to pay your bills, and then you have a medication that you need to take in order to keep up your treatment, and you go and you find out the medication is $5,000 out of pocket. So in those cases, they will call us and give us the name of the medication, and we'll do our best to overcome it. In this case, we conducted research to identify, educate the patient about, and we organized a conference call to the drug manufacturer. That's also something that we like to do for our patients. So we don't just provide the referrals, we like to take the extra step and actually make the contacts with our patients to make sure that they can get the help that they need. After calling this drug manufacturer, the investigation showed that the patient was over income for the patient assistance program. And then we located a second patient assistance program and got the patient enrolled in that one. We then did a follow-up, as we commonly do, to make sure that our efforts were successful and the patient was able to get his medication. Not only do we contact drug manufacturers, we will call copay programs with the patient to see if the copay programs can cover the medication. We also reach out to the patient's doctor sometimes and say, hey, listen, I know that this is the medication you've prescribed for this patient, but do we have an alternative? Do you have sample medications that you can provide this patient until a copay program becomes available that the patient can enroll in? We don't like our patients to be without medications. And if a patient calls in and indicates that they are without medications or they're going to be running out very soon, that case becomes urgent and someone contacts them within 24 hours. And that's simply because we understand the importance of the patient staying on their prescribed regimen. And this is just a testimonial, which as case manager, we love these because it is a testament to how hard we work and how much we love our patient. This says, my case manager has been amazing in the support she has provided. I had a procedure to ablate my prostate cancer and it was not covered. I decided to file my own claim. Following the initial denial, I found ZERO360, connected with my case manager, and from that point on felt more relaxed since I had someone who knows the methods on filing advanced claims. I saw the wisdom and thoughtfulness of her appeals and appreciated it very much. I let my urologist friends and other people know of ZERO360. I did receive some reimbursement. That is where her help was so important. Carefully crafting responses and gathering all necessary documents is something I do not know if I could have handled alone. So the bottom line is that I fully appreciate the work of ZERO360 and are glad they helped me in these matters. As I stated before, it is too difficult to summarize our services. We also do insurance appeals. We go above and beyond sometimes, even if the patient doesn't ask. We apply for all types of services for our patients. We constantly are looking for grant funds for our patients. And when we get back this feedback, we really appreciate it because we really try to treat our patients like they're our own family members. So we zealously work to help them overcome any barriers that they're facing, especially financially, just because we understand that the finances sometimes is the key to the health. So if we can get the patient health financially set, then they can focus on their health and they can get better.
Thanks, Jasmine. That was wonderful. Thanks for such a great recap of ZERO360. And I think you really hit the nail on the head. When someone is diagnosed with cancer, they need to be focused on fighting for their lives and getting treatment and staying on treatment and finding a treatment team that they trust. They should not have to be worried about all of these other things at the same time. So thanks for mentioning that. I think that's just such a great point and really drives home the need for this amazing program and for case managers like you and for people like Triage Cancer and Monica. So thank you for that. We do have a couple of questions coming in, and I think we can open the floor for just a few minutes for both Monica and Jasmine, if that works. I think the first question that I'd like to discuss and ask you is, we had a question from a man that's asking about medically necessary, in quotes, and how that is defined. Is it defined by insurance carriers? Is it defined by the government? Do those carriers have to rely on government or medical associations for those definitions? So I'm not sure who might be best, but Monica, if you want to take the first stab, I would love to open the floor to the two of you.
Sure. So what I'm assuming they're asking about is the concept of appealing an insurance company's denial. So many times in various forms of insurance, so Medicaid, private insurance, or even in Medicare, you might end up with a denial of your claim. And we as consumers have the right to appeal those denials. And the key in a successful appeal is being able to show that whatever service is medically necessary. And that is, in fact, the legal standard. Now, the second part of that question was, do they have to rely on a government standard? And my answer is, it depends. It depends on what type of insurance we're talking about. So if you're appealing a Medicare claim, then yes, there are standards set forth by the government. But typically, it's really about being able to gather enough evidence. And so it's critical to work with your healthcare team, because there's a reason they prescribed that particular treatment or asked you to get that scan or that service, to work with them to make sure that you are showing that it's in fact medically necessary. Now, there's two types of appeals. There's internal, where you go back to the insurance company, but thanks to the Affordable Care Act, otherwise known as Obamacare, every state also now has an external appeals process. So you go to an independent entity and ask them to look at the information and make a decision. And that decision is binding on the insurance company. And so when we talk about avoiding financial toxicity, and Jasmine, you mentioned appeals, I think they are absolutely imperative if you get a denial, and they're totally underutilized. We know that less than 0.5% of all denied claims get appealed. So very, very valuable to pursue the appeals process if you get a claim denial.
I just want to touch base on that question as well. From my perspective as a case manager, one of the first things I do as far as who defines medically necessary is I go into the policy and read it for myself to see what their definition of medically necessary is. Once I can get that definition, then it's a matter of contacting his provider and getting a letter of medical necessity. So not only are we then saying, hey, your policy says that this is not medically necessary. However, in this case, the prescribing doctor who sees the patient has said that it's medically necessary, and here's the reason. Then we also can get journal support, like Monica was talking about, getting the additional resources to say, hey, you said it's not medically necessary. However, in this case, and this case, it was found that this treatment actually does help patients in this exact situation. You have to appeal those not medically necessary denials. You can't let those fly, because many times they're going just off of a statute that's inside of your policy. They're not even looking at your medical records to know if it's medically necessary. They just said, well, typically if a patient has prostate cancer, they need to take Lupron. So if you're trying to get Xtandi, we don't want to cover it. So it's very important to overcome that by speaking with your doctor, as well as getting that additional evidence.
Really, really helpful. Thank you. I think we have time for 2 more questions, so I'm going to go quickly so we're not too far over. We had a man ask if there are any lists of attorneys who handle SSDI claims and appeals. And then this is a bit of a twofold question, but in addition, I think this patient has also come to see some experiences that I think we're becoming familiar with, and that prostate cancer used to have a compassionate allowance and automatic approval for metastatic disease, but it seems to be going away and evaporating here lately. So I would love to hear you both weigh in on that question or questions.
Okay, so I'll go first because my history is actually Social Security disability. I evaluated those claims for several years. And I want to just first touch on the fact that it's not that the compassionate allowance has gone away. What has happened is they also focus on your response to treatment, okay? So they're going to look at how your body is responding to treatment, and it is certain levels and certain types of responses that are needed for the approval to happen automatically. That doesn't mean that in 6 months, once they reevaluate you to see that you did not respond as you were supposed to treatment, that you won't be allowed for purposes for the claims. But it's important there is a blue book of Social Security disability blue book. It's a rule. The rules are all there in black and white. I encourage everyone before they apply for disability to read those rules, because many times if you want to seek out an attorney, that's fine. But many times if you meet those black and whites, you may not need one. So it's important to, I empower all of my patients to look at that first and not just work under the assumption that that they're going to deny you.
So I totally agree. 2 additional points. The compassionate allowances list isn't an automatic approval. You still have to show that you meet the other standards for being eligible for SSDI. And that means that you cannot work due to your disability, and that you cannot adjust to any other job, and that your disability is expected to last for a year or longer. So just having a diagnosis on that list isn't like a ticket in. It just makes that hurdle to jump a little lower, for lack of a better analogy. And so that the attorney part of that question is, one, I think you need an attorney to do your initial application. In fact, I think the more valuable ally in that is your healthcare team. I would say though, because many applications are denied on the first try and there's an appeals process, once you get to a certain level of appeal and you're going in front of an administrative law judge, then I think it can be pretty helpful to have an attorney who knows how that process all works. Now, there are definitely lists out there. I would recommend going to your state, county, local bar association to check for what attorneys are in good standing in your area. The other question we get a lot, I don't know about you, Jasmine, is, well, I'm not working. How am I supposed to pay for an attorney? The interesting thing about disability attorneys is that they're paid on a contingency basis, which means if you don't get approved and get back payments, they don't get paid. So you're not out any money up front for hiring one of those attorneys or a Social Security representative, because they're not all attorneys. So I don't think an attorney is needed on level 1. I would even say, level 2 of appeal, but definitely once you get in front of those judges, it can be helpful.
I agree 100%.
Thanks, you too. I think one last question related to ZERO360 before we sign off with just a couple of additional slides. This question is related to the regions region or states in which the ZERO360 case managers tend to have the most success. I know in our numbers that we receive from our case managers, the South region of the country tends to make up the majority of our participants in the program, but have our case managers noticed any areas of the country that they have more success in, or find things a little bit more easily to get done?
That's a loaded question. because it really depends. So you could have, I have a lot of success in my Northeast with my Northeast patients because there are more resources. There are more charity hospitals. There are more financial assistance programs. If you go really south, like Texas, where there aren't a lot of resources, Florida, not a lot of resources, not a lot of charity hospitals, and the ones that they do have very strict requirements for you to get into the programs. So it really depends on not just the region, but your particular state and your particular area, because rural areas have a really hard time with patients who need assistance. And so it's a lot of different things that go into that. But I can't say one way or the other. I can say it tends to be, you know the areas because you'll know the area you're in. And that's the only way I can say it. If your area tends to have a lot of resources, you probably will do okay. If you've called your local United Way by dialing 211, I have to do that plug. If you call 211 and they don't have anything for you, it'll be a little bit more difficult to find things because that's a testament to the fact that there may not be much in your area.
It also coincides with Medicaid expansion.
Absolutely.
Great point. Yeah, absolutely. Great point. Well, thank you both. I want to thank Monica. I want to thank Jasmine and our sponsors, Janssen Oncology and Novartis, for such an informative presentation. And to close our webinar today, I just want to highlight a couple of Zero's patient support programs, obviously very important during the COVID-19 pandemic. For all of you and other patients and caregivers to hear, you're not alone. We are here for you. I hope that's apparent listening to today's webinar, that you have a huge team of supporters behind you as you go through this diagnosis and experience. So thanks again to our speakers and to our amazing sponsors. I want to quickly highlight a really exciting upcoming event on February 28th to March 4th, 2020. Zero's annual summit is happening virtually. Of course, we would give anything to be together in person, but the safety of our community is of the utmost importance. But what this means is everyone's going to have access to this virtual event. We are shooting for 1,000 participants. We have tons of presentations and amazing speakers already lined up. A really exciting agenda. Again, another no-cost event to you. So please take a look and register today at zerocancer.org/summit. And the registration link for our summit will also be provided in the follow-up email to today's webinar. We've talked a lot about ZERO360. The phone number is there for you again. Please, to Jasmine's point, we don't want to get behind. Call early so that we don't get too far behind in bills and stress and emotional tolls that a diagnosis has. Call the program so that you can speak with an amazing case manager. Another free patient support program that Zero offers is cancer testing for prostate cancer. If you're concerned about the cost, please visit our website. We have a nationwide database of sites that have indicated they have free or low-cost screenings. I would encourage you to just give them a quick call before going, just to ensure that the COVID-19 pandemic hasn't caused changes in hours or offerings. But just another valuable resource that we are so proud to offer our community. And then we talked a little bit about our peer-to-peer support programs, but this really highlights those programs, again, free to patients, our Zero Mentor program, our Zero Caregiver Connector program. These are peer-to-peer support programs, if you think a little bit like Match.com or eHarmony for the prostate cancer community. We really like to pair our volunteer mentors with men who are going through similar battles and experiences to help them find the most invaluable community around them. Similarly, our Zero Caregiver Connector is another group where we get to match caregivers with other caregivers who have similar experiences. Finally, our Zero Connect group is our online private Facebook support group. We can connect you with more than 2,500 members. These are cancer patients, these are caregivers, family members who are dedicated to the cause. They provide amazing peer-to-peer support and encouragement for you. So please, please join us. And with that, our webinar is now concluded. As a reminder, you'll receive an email with a link to this recording as well as a short survey. We'd love to hear your feedback. We also ask you to provide topics for future webinars that we can help provide to our community. I'd like to thank our speakers and our sponsors once again, and have a wonderful evening.